co-appointed to both the adult side and the kid side, but I see him quite a lot at the children's side, and he's a great colleague, a very talented spine surgeon, as you know. So.
Yeah, absolutely, and he's the reason why this is such a familiar time for me to be talking to Toronto, because of the study group we work on together that he leads.
Yeah, that's great. Okay, just seeing a few folks coming in. We'll get going in just a moment. Okay, so Andre, I think we'll get started. So, ladies and gentlemen, welcome this morning to the Harland-Smith lectureship. This particular lectureship was posted last year, as you may recall, and because of the pandemic, we had to take a rain check on this particular lectureship. We're absolutely delighted that this year's lecturer, Dr. Sig Bervin, agreed to come back again. We had hoped that it would be in person, but sadly, once again, it's virtual. On the other hand, it's great to see Sig in this format in any case. So I'm going to ask our division head of anatomy, who is Cindy Mooreshead, to say a few words about the lectureship itself. And then Cindy will invite Albert G., head of orthopedics, because this year's lectureship has been invited by the orthopedics in the Department of Surgery to say a few words about our invited lecturer, Dr. Sig Bervin. So Cindy, over to you.
Great, thank you very much. Just wanted to put up this slide to commemorate Dr. Smith and his wife, Rita. So it's my pleasure to welcome you all today to today's university round, which is the Harland-Smith Lecture. This lectureship was endowed by Dr. Carlton Smith in honor of his wife, Rita Harland. Both Carlton and Rita were professors in the Department of Anatomy for many years. They shared a deep commitment to the University of Toronto and its students. And when the Department of Anatomy and Cell Biology became incorporated into the Department of Surgery, as the anatomy division, Dr. Smith donated funds to endow this lectureship, which is dedicated to surgeons whose career has an emphasis on the integration of anatomical knowledge and surgical practice. So we're delighted to have Dr. Albert E. today from the Division of Orthopedic Surgery organize this year's rounds. And I'll now invite Dr. Yi to please introduce this morning's speaker.
Thanks so much, Dr. Rutka and Dr. Mooreshead. It's a privilege and honor to be here today and as part of the Harland-Smith lecture. And as Dr. Rutka sort of mentioned, we had originally scheduled this for last year. And at that time, our university chair, Peter Ferguson, had been scheduled to be away. And so I was asked to sort of facilitate this on behalf of the Division of Orthopedics. So appreciate the invitation and the co-sponsorship for this lectureship today. And I really appreciate and thank Professor Bervin for continuing to accept our invitation to provide this keynote lecture today. As mentioned, we obviously had hoped it would be in person, but who would have known a year ago that we'd be sitting here with Wave 3 and another sort of provincial directive about clinical activity announced even last evening. So Professor Bervin, we, as mentioned, will certainly extend the rain check more formally and then have you in person when able. For those in the audience, Professor Bervin is a true icon in the field of spine surgery. He is the service chief of spine at the University of California, San Francisco, for which we have a very close relationship between orthopedics, our spine program, the U of T spine program, and UCSF. Several of our orthopedic and spine trainees have graduated from Toronto and completed fellowships with UCSF, some staying on board as faculty. Shane Birch has been there for quite a few years. Our very own Jeremy LaRouche at Sunnybrook has spent a few years at UCSF as well. So there's very close relationship in that regard. And Steve Lewis, as part of the deformity group, is working closely with our colleagues at UCSF on a variety of international initiatives relating to the Scoliosis Research Society. Professor Bervin has, as I've mentioned, sort of particular expertise and interest in the field of spine deformity surgery. He's developed a variety of innovative techniques, including looking at a variety of different biomaterials and implants for spinal reconstructions. And I think the topic is quite apropos to the lectureship, which really recognizes and considering the nuances of spinal anatomy as it relates to some of the newer sort of lateral, oblique, anterior type of approaches to the spine, and consideration of lumbosacral plexus anatomy, and that type of consideration in terms of our surgical approaches. Professor Bervin himself is extensively published. He's secured grant funding at all the levels, including NIH, NIAMS, and our key spine society. He's been a board member and on the editorial board of several of our pivotal organizations, as well as journals in the field. He completed his undergraduate training, I think, in Stanford, and then went off to Oxford, where he completed graduate training in philosophy, politics, and economics, before returning back to Harvard for orthopedic residency, and then completing his fellowship at UCSF, where he has stayed on as faculty since 2000. So thank you again for accepting our invitation. We very much look forward to your talk and for you spending some time with our clinical fellows later on this morning as part of our U of T citywide spine program that Dr. Michael Failings and I sort of co-chair. Much appreciated. I certainly recognize the time zone change as well for this early morning presentation, Pacific time.
Dr. Yee, thank you so much for the opportunity to contribute to this morning's lectureship. And it's a great honor for me to give this talk in the memory of Dr. Smith and Dr. Harland-Smith. I do hope it's very nice to see some familiar faces and friends on the virtual conference that we're doing this morning, and I do hope that we'll have an opportunity to have time together in person sometime soon. I'm going to talk today about the use of interbody devices in spine surgery, and we'll talk a lot about the rationale for why we use interbody devices and some of the surgical approaches, including the anatomy, and a bit about some of the design of these devices. Is my screen coming across clearly?
That's perfect.
Well, again, it's my honor to be giving this lecture in the memory of Drs. Carlton Smith and Rita Harland-Smith. And as mentioned, these were both faculty members in the Department of Anatomy. And they had endowed the lectureship with the stated goal to provide an opportunity to reflect on the fundamental relationships between anatomy and surgery. And I think when we look at the spine and pathology of the spine, as well as reconstruction of the spine, then fundamentally there is an important relationship between anatomy and surgery. And I would say that there may be no other area of the body or of medicine where there is a closer relationship between structure and function. So I'm going to talk a bit about the interbody space and some of the pathology involved in the interbody space. And I'll share with you some of the basic science, including cellular anatomy, as well as structural anatomy, that we've done some research on at UCSF. And so some of this is going to be basic science, and I hope will be of interest to the diverse audience we have, including the cell biology anatomists. Then I'll talk a bit about restoration anatomy. And when we've got compromise of our interbody space, this can lead to significant degenerative pathology, compromise of space for neural elements, and deformity and malalignment of the spine. So how might we restore that interbody space? And that also is very dependent, doing that effectively is very dependent on anatomy and a good knowledge of anatomy to really understand the surgical approaches and to find safe pathways for reconstructions. So we'll talk a bit about, again, some of the surgical approaches to the interbody space and how we do that. Initially, the talk was really focused a bit on interbody materials and design, and I'll go through that a bit, but I thought that the anatomy part of this might have been more broadly interesting, and I'll spend more time on that. Again, with regard to surgical approaches to recreate a normal anatomy or normal anatomic relationships, a normal structure to the spine, normal space for the neural elements, we'll talk about posterior-based approaches, anterior-based approaches, and lateral, including prone lateral-based approaches. The final point I will make time for at the end is the notion of interdisciplinary collaboration. And I know one of the terrific strengths of the University of Toronto, and certainly part of the legacy of Dr. Smith and Rita Harland-Smith, certainly part of that, their legacy has been to promote interdisciplinary collaboration. And certainly at UCSF, our collaboration between within our spine group, between orthopedic surgery, neurosurgery, physiatry, anesthesia, pain management, is a very strong collaboration. And I know part of this lectureship is to really emphasize that interdisciplinary collaboration. And I'll spend some time on that at the end, because I think that's an important principle. So when we think about the relationship between anatomy and function, I think that this is really clearly demonstrated in a spectrum of pathologies that affect our spinal column. A lot of my practice has to do with deformities. So you see here a patient with, on the left, with a neuromuscular scoliosis, actually a neurofibromatosis and a scoliosis, a spondylolisthesis, but all sorts of structural relationships between trauma and infection and tumors of the spine, or simple degeneration that causes pain of spinal origin. And there's a very close relationship between the anatomic deformity or the anatomic features, as well as the pathology that presents as a clinical presentation. And anatomy, of course, is a terrific teacher for this. And I go back to the words of William Harvey, who learns not from books, but from dissections, and understands that anatomy is really the fabric of nature, the fabric of how we understand the body. And in the spine, perhaps this is best exemplified, or the spine perhaps best exemplifies anatomic pathologic correlations or anatomic clinical correlations, and just understanding the basic anatomy of our nervous system, our afferent and efferent system, the muscle effectors and afferent input into our spinal system gives us a terrific ability to localize pathology. So be that pathology, perhaps symptomatic nerve compression, degeneration, weakness, and that's the basis, of course, of our ASIA scoring system. So our neurologic classification for spinal cord injury, where the level of a neurologic injury, the level of a fracture oftentimes is determined by the level above which we've got at least anti-gravity function. So this really allows us to localize pathology. And again, understanding the correlation between anatomy and function allows us to do a very effective job, even before imaging, to know where pathology may be occurring. This is actually a slide from a talk that Steve Lewis asked me to give, a session that he hosted last year, talking about spinal cord injury syndromes. And again, understanding the anatomy of our ascending and descending spinal tracts gives us specific patterns of neural deficits based on the anatomic location. And understanding this anatomy, again, gives us a lot of information about understanding mechanisms of injuries, as well as how to treat these injuries, as well as prognosis. The anatomic and structural and functional relationships, again, within the spine are made clear when we break down the spine into the functional motion segments, and understanding how a normal height of our intervertebral space by a well-hydrated disc really allows for significant space for the neural elements, including foraminal volume, as well as central stenosis. And when that intervertebral space becomes compromised through degeneration or trauma or infection or tumor or disease, then indeed that leads to predictable consequences with regard to the space for the spinal canal, the stability of the motion segments, and significant correlations between the loss of that functional motion anatomy and subsequent pathology and symptoms. The intervertebral disc really becomes central to this discussion, and degeneration of the intervertebral disc is really responsible for a lot of the degenerative disorders that we see in the spine, including disc herniations, spinal stenosis, spinalolisthesis, and oftentimes pain from symptomatic disc degeneration. The differentiation between physiologic and pathologic degeneration really hasn't been terribly well defined. But certainly pathologic degeneration is going to be degeneration that involves some component of clinical pain, but also there are chemical inflammatory cytokines and chemical profiles, as well as mechanical profiles that are different in the pathologic degeneration than physiologic. And this has been a big subject of some of the research in our basic science lab. Many of you are familiar with Dr. Lotz, who's the president of the ISLS group this year, the International Society for Surgery of the Lumbar Spine. And a lot of the work that's come out of our lab here at UCSF has been based on that. And I'll go back to some of the classic literature on disc degeneration and pain of spinal origin, and the work of Caldy-Willis, really identifying the degenerative cascade and the degeneration of the three joint complex, so the disc and facet joints. That's fundamental to degenerative pathology, and that presents with mechanical changes and instability, nerve impingement, as well as important and measurable cytokine changes and cell biology changes. Some of the work that we've done here has involved creating a degenerative phenotype. And the model that we've used has been a rat tail model. And I'll also recognize I had the opportunity to work with Steve Lipson and with Helen Muir, a student of Helen Muir actually. And they described an annular incision model. And then Jeff Oates in our lab here induced the degenerative phenotype using compression. And this is just a picture from the model that actually won a Volvo Award, one of the first Volvo Awards given to our spine group. We've subsequently won 4 others from the ISLS group. But the point being that whether we use a compression model or a stab injury model that was described by Helen Muir and Steve Lipson, or the compression model that Jeff Oates described, fundamentally, we converge to a pathway of unloading the inner collagen, of collagen denaturation, of a phenotypic alteration, and instability of the motion segment. And these are just some histologic sections from some work that we had done on degeneration and subsequently regeneration of the intervertebral disc using a combination of cytokines and cells. And just some further histologic studies showing how predictably we're really able to create a degenerative phenotype that's characterized by apoptosis of cells within the nucleus as well as within the inner annulus, and degeneration of the motion segment. In this pathway, and again, this I hope is of some interest to the cell biology folks from the anatomy area, we identified several effector cascades, and these are specifically some of the cell biology and chemical changes that are characteristic of the degenerative phenotype. And with stress and compression, growth factor deprivation, we had some activation of the MAPK signaling pathway. So this led to inflammation, IL-1 production, TNF-alpha production, and apoptosis within the disc. There was also significant activation of the NF-kappa beta pathway. And the NF-kappa beta pathway, many of you are familiar with, involves inducible nitric oxide, interleukins, and cyclooxygenases, leading to inflammatory and changes within the disc. And finally, the prostaglandin pathway, which most of you are familiar with, the idea of inducible nitric oxide leading to production of prostaglandins and subsequent acceleration of the degenerative cascade through apoptosis and through cellular biology. So I talked a bit about the cell biology and the chemistry involved in disc degeneration. Also, the physical changes are quite characteristic. So certainly we have loss of disc height and volume, loss of cellularity and cell viability, and changes in the architecture of the motion segment. And biomechanically, this really leads to changes in the load displacement curve and changes in a neutral zone. And just going back to, again, some of the classic literature in this area, Dr. Punjabi really described the relationship between instability and low back pain years ago, and really described the notion of a low displacement curve where with a normal disc architecture and normal annulus and nucleus ratio, then most motion is really within a pain-free zone, or what he described as a neutral zone. So physiologic motion really stays within a neutral zone. But with disc degeneration, there's significant alteration in the mechanical profile of that motion segment that leads to increased displacement even under physiologic load. And when that displacement gets beyond the neutral zone, and when that low displacement curve flattens, that is the underlying hypothesis under which there may be some subtle instability that can actually cause back pain with disc degeneration. And that hypothesis, I think, is really held as the basis of how we think about the relationship between disc degeneration and instability and pain. And then again, recognizing the work of another Canadian, Dr. Willis, who practiced in Saskatchewan at the university there. He described 3 different stages of the degenerative process: temporary dysfunction, where there's generally physical therapy and non-operative interventions might be appropriate. Then a stage of instability, which may actually require fusion in his assessment, and then subsequent with more advanced degeneration, stabilization, where the pathology is more characterized by symptomatic nerve compression rather than actually instability of the motion segment. And ultimately, what's the end result of this degenerative cascade? And with this background of basic science of cell biology and anatomy, the end result is, well, disc herniation, spinal stenosis, spondylolisthesis, a slippage of one vertebra upon another, deformity or malalignment of the spine, and oftentimes the end of the road is pain of spinal origin. And show now just some photomicrographs, and this is from a friend and colleague, Wolfgang Rauschning from Sweden, and these are some really beautiful photomicrographs that he put together of the spine, and in this case an axial section of the vertebral body showing normal vascularity around the cauda equina of a lumbar spine in axial section here, a coronal section here at the conus level, so perhaps the T12L1 or so, with the cauda equina coming below the conus. And in these instances, plenty of room for the neural elements. With degeneration, what we see is progressive stenosis, or compromise of the space for the neural elements. And that importantly involves a compromise of blood flow to the neural elements, which accounts for the vasogenic hypothesis of why spinal stenosis may be symptomatic, as well as important compression on neural elements that may cause demyelination and changes in nerve conduction. So you see the dramatic change in the space for the neural elements here in the degenerative phenotype, with bulging of the disc anteriorly, hypertrophy of the interlaminar ligament posteriorly, and compromise of the spinal canal. Oftentimes, this stenosis may involve the lateral recess. So here we can see, if my arrow shows up, the superior articular facet of a lumbar spine, which is ventral and lateral to the inferior articular facet. So at this 3-joint complex between the disc and the 2 facet joints, we're going to have significant compromise both of the traversing nerve roots as well as the exiting nerve roots, causing significant radicular pathology. The foramen is an important part of our anatomy, and understanding the intervertebral foramen and the dependence. So the foramen is the space between the pedicles here, and the roof of the foramen is that superior articular facet, and the floor of the foramen, or the ventral portion, is the intervertebral disc. And that foraminal volume is so dependent upon a normal intervertebral disc and a normal annulus. And of course, with degeneration and through the degenerative cascade, we could see significant compromise of that foraminal volume, where the superior articular facet suddenly drives up against the adjacent pedicle above. The intervertebral disc comes from ventrally and compresses upon the exiting nerve root. And that's a major reason for radicular pain and symptomatic nerve compression. And oftentimes this degenerative cascade can progress to an olisesis, or a forward slippage of a supraadjacent vertebra on a subadjacent vertebra. And again, you can see here quite clearly how the subsequent compression of that exiting nerve root may lead to rather predictable pathology, including symptomatic nerve compression. And I think that those photomicrographs are really tremendously valuable to demonstrate the pathology of the degenerative cascade. So why is this important? And let's bring this now from a bit of anatomy into the clinical aspect. And why is this important? Well, it's important because spinal disorders, but by any metric of importance, by measuring the prevalence of spinal disorders and the impact of spinal disorders on health rate quality of life, spinal disorders are important. And the community of physicians and anatomists and scientists, the community of people who care for patients with spinal disorders, the spinal disorders are a healthcare priority in our healthcare system. Again, the Institute of Medicine suggested that the priorities for funding, for research, for our healthcare priorities ought to be defined both by the burden of disease as well as the impact of disease. And just quantifying this, I think the global burden of disease study out of University of Washington shows this very nicely, that disorders of the spine are amongst the most prevalent and important and impactful disorders in all of medicine. So the community of physicians and scientists who take care of disorders of the spine really are a priority in our healthcare system. So let's talk then, what we talked about, some of the pathology that results from the anatomic disruption or disturbance of our interbody space. Let's talk about some of our goals of reconstruction of that space. And those goals include, to some extent, decompression of the neural elements, stabilization of the unstable motion segment. And we talked again about how degeneration leads to mechanical destabilization of that segment. A big part of my practice is deformity, both in the pediatric spine and the adult spine, and so realignment of the spine, and understanding how that realignment ought to be done with an appropriate distribution of lordosis. We'll talk about a bit. And then where anatomy becomes central to this, and a knowledge of anatomy is safety, is understanding how we can do a reconstruction of the intervertebral space, be it in the cervical spine, the thoracic spine, or the lumbar spine, and how we can do this safety with preservation of neural and vascular structures to the area. So in terms of the how and the why of interbody fusion, and Ralph Mobbs did a very nice article overviewing some of the broad spectrum of approaches we might use to the interbody space. And there's a lot of ifs, a lot of interbody fusions is the acronym here. And we'll talk a bit about some of the posterior approaches to the interbody space. So the posterior lumbar interbody fusion, the transforaminal lumbar interbody fusion. I'll start with that. Then we'll transition over to where some of the anterior approaches may be favored, and the anterior lumbar interbody fusion, as well as some variants of approaching the anterior column through either oblique or transpsoas approaches. And an important point I'll bring up again later, but with this diagram demonstrating it, is that there's a lot of acronyms here between ALIF and OLIF and LIF and DLIF and XLIF, and the idea being that interbody fusions through either an anterior, posterior, lateral, or an oblique approach. And what I think is incumbent upon the surgeon, especially the surgeon doing complex spinal reconstructions, is to have facility and ability to really utilize each of these approaches, because there are situations where there are subtle, or in some cases not so subtle, advantages to one approach in terms of a risk of complication and a potential benefit. And I think it's also important to be able to approach the spine safely from each of these avenues, because there are circumstances where each of these may have some benefit. And one of the things that this brings up again, and I'll come up with at the end, is interdisciplinary collaboration. Is that in many instances these may be approaches that weren't part of training. And for the trainees on the call, recognizing that this is a process of lifelong learning. So when I trained, certainly our posterior approaches and our anterior approaches were well known, but it's very different how I approach the spine now, largely through oblique corridors and lateral corridors, how I approach the anterior column now than when I was training. And that's something that's really, I think, incumbent upon us as practitioners to continue to learn from each other. And a big part of what we do at UCSF is we'll operate together with surgeons working together who may have expertise in some of the alternative approaches. If the anatomy looked like this, then it would really be quite easy to get to the spine from the front or the back. But indeed, there's a complex relationship of, and this is a lumbar spine, of course, but of a lumbar plexus, of vascular anatomy that really can make safe corridors challenging in many instances. When we think about our approaches, I'll start with the posterior lumbar interbody fusion approaches. This was really first described by Briggs, who used spinous processes actually as interbody material. And from an interlaminar approach, he worked around the neural elements, stacked spinous processes, and indeed got an interbody reconstruction of the space to stabilize the spine and fuse the motion segment. Perhaps more notably and more sustainably, and maybe more successfully as well, Ralph Cloward, there was a neurosurgeon practicing in Hawaii. He described the use of interbody fusion, and specifically allograft bone in the interbody space for reconstructions and disc herniation. And historically, he wrote about treating the ruptured intervertebral disc with fusion. And essentially, the purpose of this was really to restore the intervertebral space. So as we discussed, this is such an important part of our neural anatomy and of our segmental stability. So to restore both the stability as well as the space of the intervertebral region. And some of the trouble with posterior lumbar interbody fusions included troubles with graft migration, neural injuries, so trying to work around the neural elements, and relatively high rates in many instances of pseudoarthrosis, depending on graft material. To that end, I think many people now, for a posterior approach to the interbody space, are using more of a transforaminal approach, and this is really popularized by Jürgen Harms in Germany. And Jürgen Harms described taking out the facet joints. So rather than trying to work between our facet joints in a relatively, within the confines of a relatively narrow canal, Jürgen Harms described working transforaminally and working in through Cadman's triangle here, the space between the exiting nerve root and the traversing nerve root, and accessing the intervertebral disc. And the end result of that, through some comparative studies, this is a classic paper that Craig Humphreys wrote now 2 decades ago, but suggested that using a transforaminal approach is safer, can be used at more levels, and had many fewer complications than a posterolateral approach. And I put this paper in here recognizing the expertise of Raj Ramprasad and others up there at Toronto who have contributed so much to the literature. And in this meta-analysis of the literature on MIS versus open posterior approaches to the interbody space, in general, similar complications, similar fusion rates. There is certainly a learning curve to this. There was, the literature suggests higher revision surgery rates with an MIS approach, but in expert hands, including those by experts like Raj Ramprasad, that can be an equally effective approach to work with a minimally invasive approach to the interbody space compared to an open approach. Now there is what I call the Telos Paradox, and there is a bit of a paradox to posterior approaches to the interbody space. And specifically, one of our goals is to restore the foraminal volume, to restore the height of the interbody space, and also in many instances to restore lordosis. And sometimes those are competing endpoints, to try and restore lordosis of a motion segment, as well as to try and create space for the neural elements. And I'll show you this grammatically, but some work that came out of Philadelphia. Todd Albert was the lead author here, and Brian Kwan was the first author. But looking at a series of patients with an isthmic spondylolisthesis. So these patients had both a positive slip angle as well as an olisesis. And they found that they really, using a posterior interbody approach, had very limited ability to restore lordosis reliably. In fact, they were just as likely to create kyphosis as they were to create lordosis. So limited improvement of either sagittal segmental alignment or slip with a posterior-based approach. Now, we can do a better job, and Tim Kuklo wrote about this, we can do a better job of getting lordosis if we put our interbody cages more anteriorly. The trouble with that is that by putting the cages anteriorly, we can compromise our foraminal volume. By fulcruming over an anterior cage, oftentimes that can compromise the foraminal volume posteriorly. And similarly, if we put the cages more posteriorly, it'll open up the foraminal volume, but it'll reduce our restoration of segmental lordosis. One of the techniques that we've used was described by Neil Anand and Ted Goldstein down in Los Angeles, but this idea of a cantilever approach, but specifically putting an interbody graft a bit more anteriorly and taking out the facet joints posteriorly and fulcruming over that graft, we're able to get some rather impressive lordosis. And this is a patient of mine who had a sagittal plane deformity. And in this instance, you can see on the CT scan, some vacuum discs at 3, 4, and 4, 5. And this was some time ago. I chose to do this from a posterior-based approach. And just to show you that using a posterior-based approach in TLIF, the type of correction you can get with complete facetectomies posteriorly and fulcruming over that inner body graft, you can get a very effective realignment to that spine, both in a coronal plane as well as in the sagittal plane. So the TLIF can be a very powerful technique, but there can also be consequences of narrowing the foraminal volume if we create excessive lordosis. So really, the ideal operation may be an anterior approach to the spine. And what Mercer had written back in 1936 in Edinburgh, he had said, the ideal operation for fusion of the spine would be an interbody fusion, but the surgical difficulties encountered would really make that operation technically impossible. So most biomechanically stable, but technically quite difficult. And it can be technically difficult. The history of anterior lumbar interbody fusion really began in even before a Mercer statement with Burns, who did an anterior fusion between L5 and S1 for spondylolisthesis using a tibial peg. And that history has gone on with significant contributions in spine surgery, the work of Hodgson and Stock in the Ito in Hong Kong with tuberculosis for an anterior approach to reconstruct the anterior column of the spine. More commonly, we're doing these surgeries with posterior resections now, but certainly classically, that's an important development of anterior reconstruction. And just simply the anterior lumbar interbody fusion, the idea here being that we can very effectively get to the disc space, prepare the end plates, and get a relatively large interbody implant into that space. And the analogy being in the cervical spine, of course, the work of Smith and Robinson out of Johns Hopkins in the 1950s with an anterior cervical discectomy and various different methods of reconstruction by both Smith and Robinson, as well as their contemporaries for how we reconstruct that interbody space after a discectomy. So a big challenge in the lumbar spine and cervical spine is the challenge of recreating and restoring lordosis. And this is so important in our deformity, is recognized in the close association between sagittal malalignment and compromise of health status. And we know over the past decade so much more now about the alignment that we want to have within certainly the lumbar spine. When we're doing an anatomic realignment, we really want our lumbar lordosis to match the intrinsic feature of the pelvic incidence. And that's got a major impact on our planning for reconstructions. And not only matching the overall lordosis to the pelvic incidence, but also really understanding how the distribution of that lordosis ought to lie. And with a maldistribution of lordosis, that can certainly predispose our reconstructions to significant mechanical failure risk. So this is just a simple example of a patient with a post-laminectomy deformity, so an olisesis both at 4.5 and 5.1, significant kyphosis across that lumbar spine after a laminectomy. And in many ways, the anterior reconstruction is a very powerful tool for realignment of those motion segments. And you can see how well we can, from an anterior approach, and with well-positioned interbody grafts, we can really reconstruct that anterior column, recreate the space for the neural foramen, and also recreate lordosis across that L4 to S1 segment. And in contrast, this is when we don't do a good job of restoring lordosis. This is a patient with a relative loss of lordosis from L4 to S1. And this is a situation that's going to predictably lead to adjacent segment degeneration, because now this patient has lost that distributional lordosis, the region of the spine where there ought to be 2/3 of the total lordosis is now completely flat. So suddenly this person has a significant increase in stresses at the adjacent segments, and that leads to a predictable adjacent level degeneration. And in this study, there were a series of articles published in the European Spine Journal back in 2014, really demonstrating how common adjacent segment degeneration is in the subset of lumbar pelvic reconstructions that really do not adequately restore lordosis, especially in the area of L4 to S1. And one of our colleagues, Con Min from Switzerland, looked at revision surgery rates. And what he showed is that when the spinopelvic alignment, or when in lumbar fusions, the alignment from L4 to S1 was restored to close to the pelvic incidence or close to the goal, then the rate of revision surgery, the rate of adjacent segment degeneration was less than a third of what it was when those segments were left malaligned. So in these examples here, for example, L4 to S1 being fused without appropriate restoration lordosis, there's more than a threefold increase in risk of symptomatic adjacent level degeneration and the need for subsequent surgery. So a very important principle of realignment. And I'll just demonstrate this in another case I hope will be valuable, but this is a woman, 59 years old, who's got a dysplastic olisesis. So the pathology here I'll show in close-up is a olisesis, so a forward slippage of L5 on S1, there's domina of the sacrum, and this is in an older adult, a 59-year-old woman. So pretty advanced degenerative changes here between L5 and S1, and you see the dramatic compromise of the space for the exiting nerve root, and she had significant L5 both pain as well as motor deficit, as you might expect. These are just some axial sections of that olisesis, and again, just showing how severe the foraminal narrowing is in this degree of olisesis and in this deformity. So in this instance, in terms of reconstruction, my goals are to both restore some lumbar pelvic alignment, and this is something I do more commonly in children, but I give this as an example because in children I tend to do this from the back, but in this case I did it from the front. And the way I did this was approaching the spine from an anterior approach, taking an osteotome and taking off some of that inferior osteophyte. And then what I was able to do was to put on my inner body cage here to fix this to the L5 vertebra, then use my cage inserter to actually lift L5 up onto the sacrum, gently kind of having prepared the end plate of the sacrum, gradually pushing L5 onto the sacrum, and then securing that with a complete reduction of L5 onto the sacrum. You see the dramatic improvement of space for the neural foramen there. And that's we've got to be a bit careful about stretching that nerve root. But you see with that realignment, that patient had a very good restoration of segmental lordosis, as well as improvement of space for the neural elements. And that's a reconstruction that can demonstrate the benefits of an anterior column reconstruction. Well, how well and how predictably do we actually open up that neural foramen? So if anatomically what we're trying to do is to restore that disc height, especially the posterior disc height, as well as restore the lordosis, well, how well do we do that with anterior surgery? And this is a paper that was written by the lead author was one of my colleagues here, Dean Chow. Patients primarily from UCSF, and they looked at 86 patients who underwent an anterior or a lateral reconstruction of the anterior column, so 1 to 3 levels of surgery. And then they actually staged the posterior surgery. So between the first stage and the second stage, they asked the question of how much is your leg pain improved? And if leg pain was improved by at least 50%, then they percutaneously fused the back and actually did not do a direct decompression in the back. That's something I've been a little bit critical of, both because I prefer to do these surgeries in one day, but also I think that the reliability of that indirect decompression may not be perfect. And in fact, what I want to emphasize in this paper is that indeed, the subset of patients who had a good improvement of disc height and of foraminal area, foraminal height, that subset of patients actually, in many cases, did not require a direct posterior decompression, but more than almost 3/4 of the patients actually did get a direct decompression based purely on symptoms. So to that end, I think the reliability of that indirect opening of the neural foramen may not be perfect. And in 3/4 of cases, in this instance, patients said they did not get at least 50% improvement of their VAS, visual analog score for leg pain after the front stage of surgery. So they did undergo a direct decompression posteriorly. And I'll just show you that with a couple of examples. These are actually both from this week, and I thought they were relevant. So this is a woman who had a prior fusion at L4-5 done about 8 years ago and developed, she actually was decompressed at 3-4 and up to 2-3, but she had quite severe ongoing pain to the right L2 and L3 distribution. And I'll show you why on the CT scan. I think this is a very nice example of that degenerative cascade. You see the vacuum disc here at L2, 3. So a nice solid fusion with open foramen at 4, 5. But look at the 3, 4 foramen, how that superior articular facet of 4 is encroaching on that L3 nerve root, and even worse, the L3 superior articular facet, leaving no room at all for the exiting L2 nerve root. So her right, in this case, right greater than left, L2 and L3 radicular pain was quite severe. But you can see that anatomically, the stenosis is just as bad on the left side. So this is an instance where what I did in this case was to go with a direct lateral approach, reconstruct the 2, 3, and 3, 4 interbody space. But in addition to that, and you can see that from this shot intraoperatively, so I reconstructed the interbody space and lordosis at 2, 3, and 3, 4. But really, it required a posterior decompression to adequately take out that superior articular facet from the foramen of L2 and L3. You can see that L2 and L3 foramen widely opened, not only from the reconstruction of the anterior column, but also the posterior direct decompression. And already, so I did this yesterday, and already last night, she had a dramatic improvement of strength in her right quadriceps. This applies in the cervical spine as well. So this is the case I did earlier this week of a younger fellow, I think 42 years old, with achondroplasia. And in this case, he's a painter and had a fall and developed central cord syndrome, from which he had a partial recovery, but was quite severely myelopathic and had cord signal change primarily here at the C7T1. So here's an axial section at C7T1. You see the significant compromise of space for the exiting nerve roots, as well as the dorsal compression on his spinal cord here. So we had rather severe C8 radicular symptoms. And I'll just show you this again in sagittal sections, looking at the foramen of the C8 exiting nerve root here. So between C7 and T1 is our C8 exiting nerve root, how that superior articular facet of T1 is encroaching on the entire foramen, and he's also kyphotic on both sides at C7, T1. So this was a situation where I did an anterior reconstruction at C7, T1, and then after that anterior reconstruction, I turned him over, and working posteriorly, I spun the CT scan, and you can see that his superior articular facets of T1 still remain encroaching upon the exiting nerve roots. So I did an open posterior approach and took out those superior articular facets completely and widely opened the canal, both posteriorly and in the foramen. So this has evolved significantly, our anterior approaches. And when I was first doing spine surgery, routinely, we would do these long thoracolumbar approaches. And here you see we're retracting the lung. Here's the aorta. This is a T10 resection where we expose the spine all the way from T10 down to the sacrum. And now we're using much more minimally invasive approaches and approaches that involve much less morbidity. So just looking at our anterior approaches, the traditional A-lift coming from the front, working trans-psoas through the psoas, and then working more obliquely anterior to the psoas are our most common approaches to that space. And doing this through a minimally invasive approach, it's important to recognize, again, coming back to safety and anatomy, our safe zone is really defined by the space between the vascular structures anteriorly and the neural structures posteriorly. And especially on the right side, the safe zone can be very narrow. If you look at that from L4, 5, 3, 4, 2, 3, 1, 2, the width of that safe zone, especially down at L4, 5, between the vascular structures anteriorly and the neural structures posteriorly, that safe zone may be less than a third of the diameter of the anterior posterior dimension of that intervertebral space. And this is just a nice study looking at where the lumbar plexus lies along the lumbar spine and recognizing that we get less and less space with regard to our neural corridor for working in this inner body space from a lateral or an oblique approach. And knowing the anatomy of our lumbar plexus is also important here, and recognizing that many of these nerves, the iliohypogastric nerve, which innervates the transversus abdominis, may be disrupted in an approach and causes pseudo hernia. some of these nerves are more sensory nerves, or ilioinguinal, or general femoral nerve, which can be difficult to navigate through the psoas and through the lumbar plexus to get those reconstructions done safely. And of course, the consequence of this is significant complications. And in this early study of the direct lateral approach, looking at 107 patients who were treated with the direct lateral approach, 36 of these patients had a motor deficit postoperatively, and 7 of them were actually permanent deficits. Other complications, again, getting back to the important interrelationship between anatomy and complications, or anatomy and surgery, there were bowel injuries, vascular injuries, some major complications, especially during the learning curve for this procedure. I'm going to transition now just for a few minutes, and this started off as a major emphasis of the talk, but I thought that perhaps the surgical anatomy was more relevant, and maybe I'll come back another time to talk about implant materials. But when we think about what are we using now for interbody implant materials, I described early on some of the work of Briggs with spinous prostheses, Cloward and others using allograft. We've got a lot of synthetic materials now that can be used to reconstruct the interbody space, and materials including materials that effectively replace bone in the morbidity that may come from harvesting autogenous bone, or the difficulty of accessing safely cadaveric bone or allograft bone. So we've got titanium materials, PEEK materials, and other combinations of PEEK and titanium. Many are familiar with the work of Bagby, who's a veterinarian, reconstructing the cervical spine of horses for warbler syndrome. And he used interbody cages for this, and subsequently he and Kruschlitz applied this to interbody cages for the cervical and lumbar spine. These aren't used as commonly now due to subsidence, but certainly can or have been used historically. Now the type of materials we use, we tend to use autograft, allograft, and again, synthetic interbody materials. And there's a lot of interest in the impact of these materials, so some of these novel materials, on interbody fusion, or on interdigitation, as well as integration of interbody materials to the end plate to get a stable fusion. And a lot of information suggesting that there are important chemical and cellular impacts of different materials that may create a favorable or a less favorable environment for effective fusion. And a colleague of mine who helped prepare this slide, Josh Mikolas, who's working on his PhD, looking at different models to study interbody materials, either in calvarial models or intramedullary models or diaphyseal models, to see how different materials may actually grow into adjacent end plates. And this is from a paper I wrote looking at PEEK versus titanium as an interbody material. But what I'll summarize with here is just the notion that there are some novel materials, including porous materials and materials that may have the capacity to be very favorable to create an environment for new bone formation. And ultimately, what we're looking for in material development is to improve the burden of proof, I call this, is to improve fusion rates, to reduce cage subsidence, to reduce cage migration, to reduce reoperations, and importantly also to be cost effective. So I want to conclude just going back to Dr. Smith and Dr. Harland-Smith, the generous donors for whom this lecture was dedicated, and their recognized lifelong dedication to the University of Toronto. And this is a really sweet quote that was from Anne Agar, who remains one of the editors of Grant's Anatomy. And she said, "Would you like to know about Carlton Smith, the educator, the scholar, the optimist, the world traveler, the athlete, the photographer, the philanthropist?" And the notion that he was truly a lifelong learner and a generous person who made a commitment to interdisciplinary education. And hopefully I'll get invited back to speak about this, because this is something that's really a passion for me, is the notion of interdisciplinary education. And the notion that there's a lot of variability is what I wanted to show here in how we approach common conditions of the spine. And that variability oftentimes is perpetuated by an incomplete exchange of information, and really by some subspecialty-based variation. but working together between our basic scientists, our anatomists, our cell biologists, our neurosurgeons, our orthopedic surgeons, I think that's how we really develop an optimal approach. And the team that comes together to create an integrated approach, one of my passions is rowing. And going back to the story of the boys in the boat, is we need a diverse group of people to work together to really create harmony and swing, and to really create optimal care. And ultimately, optimal care is patient-centered care, and optimal care involves collaboration between multiple disciplines. So I'll wrap up with the conclusions that the relationship between anatomy and pathology, and between anatomy and surgical reconstructions, is really fundamental to how we approach spinal care and how we approach the interbody space. I think reconstruction in the interbody space is characterized by a lot of variability in surgical approaches, as well as materials that we might use, and ultimately an evidence-based approach to optimal management of spinal disorders. Optimal reconstruction in interbody space really requires the interdisciplinary collaboration, and especially between our scientists, our anatomists, and our surgeons. So with that, I'll end, and hopefully we may have some time for some questions.
Thanks so much, Professor Bervin, and you can sort of recognize the virtual round of applause. Congratulations, and thank you really for a terrific talk. I think it covers quite well the nuances in terms of leveraging our understanding of anatomy and to sort of localize pathology, as well as considering it in terms of our approaches. And you covered the spectrum from materials to biomechanical and biological considerations as well. So we do have some time for maybe one or two questions. I guess Professor Failings, and then I think Professor Lewis, I think, has his hands up as well.
Sig, thank you for the wonderful talk, and it was really a tour de force. A note of appreciation for recognizing the importance of Kirkcaldy-Willis, and I think that's often lost in the mix. The huge contribution that this Canadian surgeon scientist made in terms of the understanding of degenerative disc disease. So my question kind of relates to going beyond reconstruction. And do you see a realistic role for regenerative medicine in the treatment of degenerative disc disease? So rather than taking out the disc and replacing it with an implant, do you think it might actually be realistic to regenerate the disc, or to repair the disc?
Michael, normally I'm asking you that about the spinal cord, whether we regenerate the spinal cord and neural.
The question is to you.
but I'll take this. And a lot of the work that we've done at UCSF, and I'll also recognize work that's been done by Jim Kang and others, has been with the goal of regenerating discs. So the reason we developed, or Jeff Loach developed, the phenotype for disc degeneration was both to describe the pathophysiology of degeneration, again, the chemical changes and the structural changes, but also to create a model which we can reproducibly use for regeneration. So we've done quite a bit of work now in using various mesenchymal cells, as well as various different types of synthetic materials to try and regenerate and restore the height. It's a very unfriendly environment for regeneration, as can a syrinx in a spinal cord be, right? It's a very unfriendly environment in terms of cellular compatibility or the viability of cells in that space, the vascular supply there. I think that a regenerative strategy is probably going to involve a combination of cellular restoration, as well as perhaps mechanical stabilization and improvement of the end plate porosity or end plate permeability for a viable regenerative technique to be used. Or perhaps it may have to be earlier in the phase of disease when there's not that segmental instability or loss of segmental stability. So right now, I don't think we've got a terrific regenerative solution that's available practically. The most recent work that was done by the Mesicult group is somewhat positive. Their phase 3 trial has just come out, which suggested that compared to control, stem cells, actually specifically commercially prepared stem cells, may have some effect size with regard to both clinical outcomes as well as some anatomic outcomes. but I think a lot more work needs to be done there, and figuring out exactly what the right stage of degeneration is for that intervention is also a big challenge.
Thank you.
Okay. We've got a question from Steve Lewis, and then there's a text question from Dr. LaRouche.
Hi, Sig. Congratulations on a great talk and a great overview. What I was hoping just to maybe to organize for our trainees and things is your approach to the interbodies. Usually when we say when there's more than one approach, none of them are very good. And what is your kind of approach to the interbodies? When are you going from the front? When are you going from the side? When are you going from the back? When are you doing a P lift? When are you doing a T lift? And then what is your kind of number one implant material that you choose in 2021?
Yeah, thanks, Steve. And Steve, I blamed you earlier for the fact that this isn't such an unfamiliar time for me to be on the computer, because you organize these research group meetings at 7 o'clock Toronto time, which is 4 o'clock in California. So having said that, in answer to your question about when to use which approach, part of the point I wanted to make is I think it's really incumbent upon us as effective surgeons to be facile with each of the approaches. And in my hands, the posterior interbody approaches I use most commonly in my pediatric population in a high-grade spondylolisthesis or a dysplastic spondylolisthesis. I like to do a doming of the sacrum, and I can actually pull the L5 back and be very safe around the neural elements. So even though I showed an example of reconstruction from anteriorly, the dysplastic spondylolisthesis I tend to do from the back, and single level degenerative pathology, so degenerative spondylolisthesis, I tend to do that from the back as a single stage surgery where I'm maybe not as concerned about realignment of the spine. Where I'm using my anterior approaches is much more commonly when I'm really trying to restore lordosis, to try and match my lumbar lordosis to the pelvic incidence, and to try and get a distribution of lordosis such that 2/3 of that lordosis is from L4 to S1. In my hands, I really favor the A-lift from L3 to S1, a paramedian approach to the anterior spine. I find that with the patient supine, taking down the ALL completely, taking down the PLL, getting a restoration of posterior height, I actually work my A-lift implants based on posterior height. So I'll go from 4 millimeters up to 8 millimeters of posterior height. And I find that I've got the best ability from L3 to S1 with a supine patient and a paramedian approach. Having said that, I also do have some facility with the anti-psoas and trans-psoas approach, where typically above L3, I'll use that approach. I haven't been a big fan of single position surgery. This is a whole nother topic, but I think that there's a moral hazard to spine surgery. And what I mean by that is that there's a disassociation between risk and benefit. And I think with a lot of single position surgery, the surgeon's getting the benefit, perhaps of this being a little more efficient. In my hands, often not, but it's at the cost of effectively restoring lordosis and of safely addressing the interbody space. So, and then just very briefly in terms of materials, I tend to favor allograft and cervical spine for my anterior cervical discectomies and fusions. We wrote about that with Khoi Tan, showing much better results in terms of fusion rates and subsidence for allograft compared to PEEK. In the anterior approaches, in my A-lifts, I tend to use PEEK with BMP, and the reason for that is that there's been some allograft problems with BMP, so I tend to use PEEK with BMP. And in the posterior approach to interbody, I favor titanium based on some of the histology work that we did with osteointegration of titanium.
Thanks, Laz.
And I think the last question that we have is a nice segue to that. Dr. LaRouche was asking about thoughts in terms of the indirect decompression. Obviously can help sort of foraminal height and so forth, but effects, I guess, on lateral recess and the central stenosis that often coexists.
Yeah, Jeremy, such an important question. And I agree completely with your observation. I think that the indirect decompressions to restoring disc height, especially posteriorly, does a very nice job in many instances of opening up the neural foramen in terms of the height of the foramen. But what doesn't really get affected significantly is our central stenosis or lateral recess stenosis. And I think in patients with central and lateral recess stenosis, I'm even more likely to do an open posterior decompression. You know, to some extent, by restoring disc height. We have some theoretical, putting the interlaminar ligament perhaps under some tension, some work that's been done, including looking at the X-stop posteriorly or anterior interbody reconstructions. There can be a little bit of a stretch of that interlaminar ligament, reduction of the redundancy there. But I think in terms of the reliability of decompressing the neural elements, the foramen is most reliably decompressed. But even in the examples that I showed you, the paper by Mumaneni and the group here at UCSF, almost 3/4 of those patients who had an anterior column reconstruction still had enough either foraminal or central stenosis that they required an open decompression. So overall, I'm not a terrific fan of indirect decompression alone. I think that the reliability of that is at best moderate, especially for the lateral recess and central stenosis, especially there.
Okay, so terrific. So thanks again for an exceptional talk and a great discussion. So Dr. Fehlings had provided, I guess, a link for those interested in the case presentations that will follow. And I hope everyone continues to be well and safe. Many thanks, Dr. Ruck, Dr. Morshead, for this opportunity and showcase some of orthopedics as well as spine surgery.
Great. Thank you, Sig.
Thanks, Sig.
Thanks to everybody. Look forward to seeing you all soon, and please be well out there and be safe during this difficult surge. Look forward to when it's safe to be together again soon.
You bet. Thanks, Sig.
Absolutely.
Thank you. Thank you.
Bye-bye.